The seasons, they do change. It is September 1st. The summer is over. But the Puscast continues. Lucky you. Welcome to the Persiflager's Puscast. Review the infectious disease literature with my commentary, covering the last 2 weeks of August 2010. For those of you who are sick of the intro, you can always skip ahead, but there are things I must say. I must, because it is CME accredited. This is brought to you by Pusware LLC, the publisher of the Persiflager's Annotated Compendium of Infectious Disease Facts, Dogma, and Opinion, your uber hyperlinked electronic guide to infectious diseases at moremark.squarespace.com, where you will find also the iPhone, iPad program, and all things in my growing multimedia empire. This is CME accredited. So when you're done, take the online quiz and get a half an hour of free CME. Thanks to Legacy Health. Because it is CME accredited, I must mention that I have no conflicts of interest except for the huge income I generate through my website, which is actually just enough to cover the bandwidth. Thank you to all those who have been kind enough to donate a few dimes my way. As always, my demand is not that you send me money. Not that I would object, mind you. I do like money. But go onto iTunes and rate me highly. Give me a glowing review. My fragile ego demands it. And of course, as I mentioned above, you can find all things Mark Crislip over at moremark.squarespace.com with links to all my blogs, my podcasts. But I don't do Twitter, and I don't do Facebook, and I suppose I should, but I really want to join an antisocial network. It takes less time. But now on to the literature. If there are themes in this podcast, one of them is the effect of large-scale changes on the incidence of human disease. I have talked at some point in the past about the articles that suggest that the only times that global warming has slowed down on Earth has been during plagues, and when large amounts of human beings die, as happened with the great deaths of the Middle Ages, that CO2 emissions fall, farmland is converted into trees, which absorb CO2. There's, of course, less animals producing gas. So, great die-offs of humans have been good for global cooling. This article looked at the issue as to whether or not climate could be an inducer of plague. They looked at the effect of rainfall on gerbil populations and subsequent plague outbreaks and found recently that what would happen is if you'd have wet season in gerbil land, there'd be an increase in gerbils, the great gerbil carrying bubonic plague, and subsequent outbreaks of the disease. They looked at historical records, and of course it's difficult to determine climate based on historical records, but you can use things such as tree rings. And looking back, they found a reasonable correlation between wetter seasons and subsequent outbreaks of bubonic plague. So with global warming, some parts of the world, of course, are going to become drier, but other parts may get wetter. And with wetter weather will become more rodents as they get more food supply, and with it, you get more bubonic plague. That happened in India at the end of last century, where a very big and successful wheat crop led to an increase in the rodent population and the subsequent outbreak of bubonic plague. I think that was like 1992 or so. So it's not totally out of the picture. And how climate is going to alter infectious disease in the future, well, of course, time will tell. Some huge chunk of our DNA is actually old viruses that got incorporated and never escaped. Evidently, a whopping 8% of our DNA is old Bornavirus sequences that have never escaped from our DNA. It's remarkable how much of us is actually someone else. But persistence of virus is a problem in human beings. And some infections, unlike love, are forever. Take the JC virus, please. Y'all know that, see, I'm from the South. Y'all know that the JC virus causes PML, progressive multifocal leukoencephalopathy, a horrible brain melting disease of AIDS patients and some other immunoincompetent patients. The problem with this is that it's a reactivation disease, and this study looked at JC virus latency not only in the brains but in other organs of patients who did not have PML. Now, obviously, harvesting brains outside of a George Romero film is somewhat awkward, but when they tested HIV-negative individuals, they found evidence of JC virus DNA in 26%. Now, that's only 5 of 19, but still a quarter of people had evidence of JC virus. And I'm certain there's some sampling issues here, since it's not always easy to get large quantities of brain. They also found it present in kidney samples and bone marrow. So it can be found extraneurally as well. It was not found in spleen or lymph nodes. So JC virus is found maybe in a quarter of normal people, ready to reactivate once their immune system is whacked. We have all these HIV medications, and they have truly revolutionized the disease. Remember back in the day when everybody with HIV would die in about 9 months. It was terrible. The thing is that nowadays you put people on heart and they suppress their viral load, their CD4 counts come up, the sun shines, there's peace on earth, the lion lays down with the lamb. But what happens to people who fail their first suppression? Does that make a difference in subsequent immune reconstitution? And it turns out the answer is yes. That the more times you have failed with your HIV, the longer it takes to get to CD4 cells greater than 300. If you failed once, it takes 34 months. If you failed twice, 41 months. If you failed 3 times, if you fail 3 times, it takes 51 months to get back your CD4 counts. So really, your first chance to get your CD4 counts above 300 is best with your initial therapy. And really, although we do have backups, it's really important to get the patient suppressed and the viral load down and the CD4 counts up the first time through. And I assume I'll be sued by Lionel Richie for that horrible imitation. I've harped on this issue before, that infections are a pro-inflammatory state, but pro-inflammatory states are also pro-thrombotic states. And inflammation and thrombosis can sometimes be bad. Now, how about HIV patients? It's long been known that they have an increased risk of cerebrovascular accidents and TIAs, and they also have an increased risk of cardiovascular events. In part, this has been blamed upon the patient's medications, which tend to incite diabetes and other atherogenic complications of HIV medications. Now, this study looked at just CD4 counts alone and found that CD4 counts under 500 were in and of themselves a risk factor, independent of antiretrovirals and the other classic risk factors for HIV disease. As they point out in the article, quote, lower CD4 cells are associated with elevated serum markers of inflammation and increased levels of activated CD4 cells. Activated CD4 cells are frequently present in atherosclerotic lesions in the general population. Our hypothesis, of course, is that the pro-inflammatory state of HIV is also a pro-thrombotic state and leads to increase in atherogenesis. All the more reason, however, to modify the traditional risk factors of cardiovascular disease in this population, such as smoking, exercise, etc. I did my residency, internal medicine, in Minneapolis as part of the Hennepin County system. One of the things that was very impressive about Minnesota was the mosquitoes. I've never seen so many mosquitoes than when I tried as an intern to go camping for one of my vacations. I think my hemoglobin dropped about 4 points. Why do you care about my problems with mosquitoes? Well, there was a group of U.S. travelers who went to the Dominican Republic. They were going for missionary work, and they came back to Minnesota and Iowa, and they all came down with dengue hemorrhagic fever. Well, I should say dengue fever. And it was a well-described outbreak. Here's the thing that would worry you under these circumstances. It is conceivable that if you have a large group of people coming back from the Dominican Republic with dengue, they all get bit by mosquitoes once they get home, you could have dengue endemic again in the United States. It's already being found in Florida, and people are seropositive along the Texas-Mexican border in Brownsville. So it's only a matter of time probably before dengue becomes endemic in the United States. And with global warming, they estimate that could get as high as Manitoba, Canada. Something to look forward to. Infections are due to the interplay of 2, sometimes 3 factors. First, of course, is the virulence of the bacteria. Second is the ability of the host immune system to deal with said infection. And then, depending on the infection, the efficacy of antibiotics. But often people live or die or do well due to surprisingly little things. For example, NSAIDs are associated perhaps with an increased risk of developing necrotizing fasciitis if you have group A strep. That's a debatable statement. I think the data is at least suggestive that way. How about for pneumonia? This study looked at NSAIDs and community-acquired pneumonia and found that patients who were on NSAIDs early in their community-acquired pneumonia had a more complicated course but had less of a response, which was associated with both a delayed diagnosis and a longer hospitalization. Allow me, if you would be so kind, to quote from the article. Quote, they developed more often pleural pulmonary complications such as pleural empyema and lung cavitation. 37.5% of those on steroids versus 7% of those who were not. And they had a trend to more invasive disease, had a higher frequency of pleural empyema, for 25% versus 5%, and bacteremia, especially in those not having received concomitant antibiotics. Nevertheless, the NSAID patients had no more severe systemic inflammation or remote organ dysfunction, end quote. So, you need inflammation to keep the infection at bay. And if you take off just a little bit of inflammation, as NSAIDs do, you end up with more complications in pneumonia. Compare and contrast that, of course, to the statin literature, which suggests that use of statins is associated with decreased morbidity and mortality with a wide variety of infections, perhaps or perhaps not, due to alterations in the inflammatory system due to the statins. Of course, the statins are working in a slightly different place than the NSAIDs, so I may be comparing apples and PCs. But nonetheless, NSAIDs, infections, bad. Occasionally, it comes up when talking about catheter infections, about having the inside of the catheter, quote, colonized, unquote, with bacteria, i.e. you have an intraluminal bacteria, but it's not an infection. To my way of thinking, if you have bacteria in what should be a sterile site, i.e. the lumen of the catheter, you have an infection, not a colonization. You can only have colonizations of sites that are not supposed to be sterile. Now, this particular study looked at, quote, colonization, unquote, of dialysis catheters and found that when patients had positive blood cultures drawn through their dialysis catheters but were otherwise asymptomatic, that they had a high probability of going on to developing a bloodstream infection. What is a high probability? 100%. So to my way of thinking, if you have an infected intraluminal catheter, you have a catheter infection. It just hasn't marched down into the bloodstream yet. Now, this looked at staph epi as a cause of catheter-related bloodstream infections. And interestingly, the time from endoluminal colonization to symptomatic infection was about 30 days. So if you draw blood cultures through at least a dialysis catheter and you get coagulase negative staphylococci, and presuming you have superlative technique, that you have a high probability of having a future catheter infection, especially if the time to positivity of your cultures was less than 14 hours. So let's hear no more of this colonization of the lumen of a catheter. It's a sterile site. If you're growing bacteria, it's infected. You just haven't become symptomatic yet. You got your trimethoprim sulfamethoxazole, or as we called it back in the day, Bactrim. Now, trimethoprim sulfamethoxazole works at two different enzymes. The trimethoprim component, and pyrimethamine as well, inhibit the dihydrofolate reductase. Sulfas, sulfamethoxazole, dapsone, for example, inhibit a drug that I'm going to mispronounce, dihydropteroate synthase. For hoots and giggles, we'll just call it DHPS. Now, there are Pneumocystis jirovecii that are resistant to TMP sulfa, and they do it by having a mutation in the DHPS enzyme. Now, there have been resistant pneumocystis that have had DHPS mutants that prevent pneumocystis from being treated with sulfa drugs. I've heard about it being described in San Francisco. This study compared and contrasted, it wasn't like an old college study, compare and contrast. They compared and contrasted pneumocystis in Lyon, France with Switzerland. They found that the DHPS mutations were very high in Lyon at 33% versus a mere 7.5% in Switzerland. Now, the interesting thing is that in Lyon, they did not do measures to prevent the airborne spread of pneumocystis, whilst in Switzerland they did. And we've talked in prior studies, or prior Puscasts, how pneumocystis has a high probability of being spread. They determined by looking at the genetic analysis and the epidemiology that a lot of the resistance was being spread person to person and not being spread by new mutations that were occurring because patients were on suboptimal prophylaxis with pneumocystis. So the key thing here is that pneumocystis is spread person to person, and if you have a resistant strain, it could be spread to other HIV patients. And part of the evidence to support that was the mutated pneumocystis was being found in patients that had never been treated with sulfa drugs. I'm not certain what the infection control impact of this data is. Certainly, if you have a pneumocystis patient, they should not be waiting in the HIV anteroom or the renal transplant anteroom, or the uncle room for that matter. But what to do overall is still, to my mind, uncertain. TB or not TB, that is the congestion. I'll quote directly from the article. Treatment of TB is generally believed to reduce infectivity rapidly. Many hospitals in the industrialized world consider 2 weeks of therapy to be sufficient to permit patients to leave isolation room. This dogma arises from observations made greater than 30 years ago describing limited transmission from patients undergoing treatment to their contacts and from the known rapid bactericidal activity of isoniazid. Conversion from smear positivity to negativity, and don't be negative, is often considered to be an indication of non-infectiousness. However, recent data indicate the variability of infectiousness of treated patients cannot be accounted for solely by smear status, end quote. So what they did in this population of patients out of Peru was look at both smear and culture positivity. And they found that patients remained culture positive and pan-susceptible tuberculosis for almost 39 days. That the mean time to culture conversion was 37 days, and 10% of patients with susceptible tuberculosis remain culture positive for 60 days. So this does have some interesting problems in determining when you can take patients out of isolation. The persistence of smear positivity was also a poor predictor of multi-drug resistance in this study. But people with tuberculosis, just because they are smear negative, doesn't mean they are necessarily not infectious. And certainly I wouldn't want to have a tubercular coughing in my face for at least a month after beginning multi-drug therapy to which the organism is susceptible. And now, your favorite part of the Puscast and mine, the hodgepodge. A quick summary of a bunch of stuff that I don't feel like referencing. That's why God gave us Google. First up in our hodgepodge, chronic hepatitis C due to a persistent parvovirus B19 infection. Unusual, but there you go. Influenza. Well, the CDC looked at influenza and found that death rates vary year to year. No big surprise. 1986 flu season, there was only 3,000 deaths. Not an only if you're one of the ones to die. 2003, there were almost 50,000 deaths, right up there with handguns and automobiles. Interestingly, when you had H3N2 strains, they were much more lethal than seasons that did not have H3N2 strains circulating. Rocky Mountain spotted fever is increasing in incidence, or maybe just reporting, in the United States. The case fatality, however, has decreased, so people are making the diagnosis more and treating it more appropriately. There's an article about HIV patients manifesting their syphilis with eyeball findings. I've seen a half dozen syphili? I don't know, present primarily with ocular findings. Just remember, anybody who presents with an inflamed eyeball thinks syphilis, especially if it's HIV or men who have sex with men. One way to reduce infection after PEG is basically to put antibiotics into the gastric tube. They compared that to IV therapy, and they found that intra-stomach TMP sulfa was as good as IV cefuroxime for preventing G-tube infections. By the way, yet another study, this one out of Japan, showing that when you have Staph aureus bacteremia, having intervention by your infectious disease practitioner decreases mortality and improves utilization of patients with Staph aureus bacteremia. So as always, if your patient has staph in the blood, they benefit from an infectious disease consultation. Another staph article looked at the presence of the Panton-Valentine leukocidin, a protein that comes around every February 14th. And if patients have a PVL positive MRSA, they have a much higher chance of going on to developing bacteremia. So PVL is a bad thing. Unfortunately, we cannot test it in clinical specimens. If you give the right antibiotic up front for MRSA, i.e. vancomycin, you have an increased 14-day survival than if you give an alternative agent, i.e. beta-lactam. And also when you're dosing the vancomycin, you should make sure the patient gets at least a gram Q12. The other thing that was associated with survival was giving at least 2 grams a day of vancomycin, starting it within 48 hours, and of course giving vancomycin instead of an alternative agent. Women who have urinary tract infections, well, like legs, noses, the staph infections runs in families. And they found that if one female in the family had E. coli UTI, other women in the family were also likely, suggesting that there's a genetic component to developing cystitis. It's always argued whether or not you should get blood cultures on patients when they show up in the emergency room, especially for common infections like community-acquired pneumonia or just fever. But if you show up with positive blood cultures, your case fatality ratio, both crude and attributable, are 20% and 12% respectively. Having positive blood cultures is a bad thing. and you need to know if bad things are about to happen. Malaria commonly causes hyponatremia, and severer diseases cause worser hyponatremia. What to do about it? I don't know, but it's one of those interesting findings. It was suggested once upon a time that cefepime was associated with increased mortality compared to other cephalosporins. A recent meta-analysis of this in the Clinical Infectious Diseases showed that this was not true of cefepime-treated patients treated with other antimicrobials. So overall, it looks like cefepime is just as good as other cephalosporins for treating patients with sepsis or other infections. And finally, should you give beta-lactams alone or with an aminoglycoside in patients who have bacteremia? Now, my bias is that you should give both for patients who are septic. One, because you get some synergistic killing and maybe will increase your survival rate. But two, if the patient gets monotherapy and your patient happens to have a bug that is resistant to that monotherapy, mortality rates in studies increase anywhere from 40 to 60%. And with increasing resistance, with expanded spectrum beta-lactamases, etc., having resistance is a problem that is increasingly going to make empiric therapy problematic. However, in this study, quote, we could not find an overall association between empirical beta-lactam aminoglycoside combination therapy and prognosis. Bummer. But there are other studies that do support this. But as always, when it comes to the question of combination therapy for the treatment of gram-negative infections, the jury is still out. And they're out having a beer. So you don't want them ruling against you in a court of law. So, as Click and Clack would say, you managed to piss away another 27 minutes of your life that you will never, ever get back, listening to the fabulous yet mellifluous voice of Mark Crislip, your Puscaster. References for this fabulous Puscast are available on the website. It's CME accredited, so now that you've listened to my droning for the last half an hour, take the quiz. Get a free half an hour of CME thanks to Legacy Health. And listen, don't take the quiz before you listen to the Puscast. That's cheating. This is brought to you by Pusware LLC, publisher of the Persiflager's Annotated Compendium, your infectious disease guide of facts, dogma, and opinion. It's available on the interwebs, and it's an iTunes application. And it does work on the iPad. At least it works on my iPad. If it doesn't work on yours, drop me an email so I can figure out why. Also, don't forget all the other components of the Mark Crislip multimedia empire, my Quackcast, my infectious disease blogs, my science-based medicine blogs. I mean, really, the world does need more Mark Crislip, and I'm providing it to you, pretty much free of cost. However, bandwidth ain't free, so feel free to purchase the compendium by the iPhone app or send me $10,000 in small unmarked 20s. I deserve it. This is copyright 2010 under the Creative Commons license. The music is by my son when he was 12. He's now a senior. He's going to college next year. I can't cope. I'm getting old. But he was 12 when he was improvising on the guitar that makes up the music for this podcast. And as always, thank you for this most interesting consultation and allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation, goodbye.